This recorded lecture will be going over Chapter 16, Care of Patients with Hematologic Disorders. Anemia is a state in which there are insufficient numbers of functioning red blood cells or a lack of hemoglobin to meet the demands of the tissues for oxygen. Anemia is not a disease. It is a symptom of a disease or pathologic process. It can be chronic or acute. There are three major classifications of anemia according to cause: anemia resulting from blood loss, anemia resulting from a failure in blood cell production, and anemia associated with a destruction of red blood cells. Rapid, severe bleeding will lead to anemia due to blood loss, hypovolemia, and potentially shock. Anemia caused by a failure in cell production is the result of either a deficiency of certain substances necessary for the formation of red blood cells or abnormal functioning of bone marrow. Examples of this type of anemia are nutritional anemia, anemia resulting from bone marrow suppression caused by toxic substances, megoblastic anemia or pernicious anemia, in which there is faulty absorption of specific nutrients like vitamin B12, or end-stage renal disease, where erythropoietin is not produced by the kidney, so therefore red blood cell production is not stimulated. On page 351 within Table 16.1, you can read about some causes of anemia. Anemia caused by destruction of red blood cells could be inherited or acquired. Hemolytic anemia can be a result of genetic defects that affect cell structure, causing the cells to disintegrate quickly. Immune reactions can cause blood cell hemolysis. The presence of toxins in the blood, infections like malaria, transfusion reactions, and changes in blood chemistry can all cause red blood cell hemolysis. Iron deficiency anemia occurs when total body iron is insufficient and erythropoiesis is diminished. In megoblastic anemia, an autoimmune disease, the intrinsic factor is missing from the gastric juices, and vitamin B12 is not absorbed without it. To treat this condition, vitamin B12 will be given and any folic acid deficiency corrected. Hemolytic anemias associated with excessive destruction of red blood cells are quite rare. Anemia occurs during end-stage renal disease when there is a deficiency of production of erythropoietin, a substance necessary to stimulate the creation of red blood cells in the bone marrow. This problem is usually corrected by the administration of erythropoiesis-stimulating agents, or ESAs. This would include epoetin alpha and darbepoetin alpha. Oxygen transport will depend on the number and condition of the red blood cells and the amount of hemoglobin they contain. On page 352, see the purple clinical cues box. When a patient has had a gastric bypass surgery or a gastrectomy, there is a risk of megaloblastic anemia from the resultant disease of available intrinsic factor. Observe your patient for any signs of megoblastic anemia. This concept map can be seen on page 352. Signs and symptoms of anemias from causes other than rapid bleeding will depend on whether the anemia is mild, moderate, or severe. Signs and symptoms of mild anemia, which would occur at a hemoglobin from 11 to 13 grams per deciliter, include a mild headache, palpitations, and dyspnea on exertion. Moderate anemia, which occurs at a hemoglobin level of 8 to 10 grams per deciliter, could include brittle nails, sore tongue, pallor, chronic fatigue, headache, and dizziness or faintness. You can read about the signs and symptoms of severe anemia within Table 16.3 on page 353. The microscopic appearance of the red blood cells in a film of blood that has been spread over a slide, known as a peripheral smear, will give information about abnormalities in size, shape, and color of erythrocytes circulating within the patient's bloodstream. The CBC and a differential cell count results can be used to diagnose the presence of anemia. Anemia will be diagnosed when hemoglobin levels drop below 13.5 grams per deciliter in men and 12 grams per deciliter in women. A normocytic normochromic anemia is characterized by cells that are normal in size and color, but have a deficiency in the number of red blood cells as well as a low hematocrit. This type of anemia typically occurs as a result of sudden blood loss. A hypochromic microcytic anemia is characterized by decreased levels of hemoglobin and small microcells. This type of anemia is typical of an iron deficiency anemia. Correcting the underlying problem and then building up replacement blood cells will treat anemia from chronic slow blood loss. Anemia caused by inadequate iron, folic acid, or protein intake can be managed with oral iron supplements, vitamins, and diet adjustment. If the anemia is serious, blood transfusions may be given or IV iron preparations can be administered. Megaloblastic anemia is treated by regular administration of vitamin B12, either by injection, orally, sublingually, or intranasally. For hemolytic anemia, the underlying cause is found and corrected if possible, and then the blood volume will be rebuilt with added iron and appropriate diet or administration of an ESA. On page 354, within Table 16.4, you can read about some drugs commonly used to treat disorders of the hematologic system. Whenever a patient complains of fatigue, headaches, or shortness of breath, anemia should always be considered. Intervention is based on an understanding of the kind of anemia affecting the patient. For patients with anemia that interferes with clotting and that tends to cause bleeding episodes, nursing actions will be directed towards preventing those episodes. For any patient with anemia severe enough to cause fatigue, assist with activities of daily living and provide planned rest periods. Nursing functions will include administering blood, iron, vitamin B12, and folic acid, as well as monitoring for the desired effects. Patients should be taught that iron is absorbed more readily if vitamin C is simultaneously present in the GI system. Laboratory values will be particularly important when evaluating the care for a patient with anemia. Aplastic anemia, a rare disorder, can develop after a viral infection, as a reaction to a drug, or due to an inherited tendency. The disease is characterized by bone marrow depression and is believed to probably be an immune-mediated disease. The toxic effects of certain substances can be responsible for aplastic anemia. Some of these agents would include benzene, insecticides, drugs like chloramphenicol, phenylbutazone, and sulfonamides. Some anticonvulsants, gold compounds used to treat rheumatoid arthritis, and alkylating agents or antimetabolites used in chemotherapy. Radiation exposure is another factor in the development of this disorder. Impairment or failure of bone marrow function leading to the loss of stem cells is the actual cause of aplastic anemia. In addition to the signs and symptoms of iron deficiency anemia, ecchymosis, petechiae, and hemorrhage related to low platelet count will also occur. Infection is common and may not cause an inflammatory response due to the very low leukocyte count. There is often frequent bleeding in the mouth. Diagnosis can be made by blood count with differential, bone marrow biopsy, and ruling out other disorders. Aplastic anemia will cause an emergency situation. Packed red blood cells and platelets are administered. Hematopoietic cell transplantation, or HCT, also known as bone marrow transplantation, is the treatment of choice for patients younger than 50. This concept map can be seen on page 357. Prevention of hemorrhage and infection is a top priority, and safety measures are another priority. Sickle cell disease is a genetic disorder in which the gene is inherited from both parents. This is known as a homozygous gene. Sickle cell disease is characterized by gene mutations that cause the production of abnormal hemoglobin S rather than hemoglobin A. Sickle cell trait is heterozygous, meaning that the person has an inherited gene for the trait from only one parent. People with heterozygous trait for sickle cell are known as carriers. They can transmit the gene to their children even when they themselves do not show signs of the disease. The defective hemoglobin S will polymerize when hypoxia is present, causing them to assume a sickle shape, blocking blood vessels, breaking apart, and forming thrombi that cause organ damage. HbS has a lifespan of 10 days compared to the 120 days for normal hemoglobin. This image can be seen on page 358. Also on page 358 is table 16.5, where you can read about the comparison of the 4 types of anemia. The most common cause of death from sickle cell disease is acute organ failure due to impaired circulation. When cells clump, blood flow is impaired, and the signs and symptoms are those that would indicate a lack of oxygen and blood flow, like pallor, lethargy, and pain. Periodic episodes of pain are called sickle cell crisis, and they indicate a lack of blood flow in the small vessels. Painful swelling of the hands and feet related to bone infarction due to the sickled cells, also called hand-foot syndrome, could occur. Most cases will be diagnosed in infancy with blood testing of newborns. Whether the patient is a newborn, child, or adult, a high-performance liquid chromatography is the test of choice for diagnosis. During crisis, there will be elevations of serum bilirubin due to the hemolysis of the abnormal red blood cells. Skeletal X-rays reveal bone and joint abnormalities. Sickle cell disease is a chronic condition that is not reversible at this time. Treatment will be focused on prevention of sickle cell crisis and managing the symptoms when crisis occurs. Patients should be taking folic acid regularly and eating a diet with sufficient protein to help build red blood cells. Infection is to be prevented, and the patient should receive all recommended immunizations against influenza, hepatitis A and B, pneumonia, tetanus, and other diseases. Adequate intake of fluid daily is important to keep the blood as fluid as possible. Alcohol and other recreational drugs should be avoided. The drug hydroxyurea has been found to reduce the frequency of sickling episodes. An alternative medication for those who cannot tolerate the hydroxyurea is pharmaceutical grade L-glutamine. If a crisis occurs, the patient could be treated at home with bed rest, adequate fluid intake, and analgesics. Pain control is important during a crisis. Narcotic analgesia with morphine can be administered on a continuous basis, usually by a PCA pump. There are many complications of sickle cell disease, including cholecystitis, stroke, pulmonary embolus, congestive heart failure, and damage to all major organs. One of the most common problems is leg ulcers due to impaired circulation to the legs and feet. Protecting the feet and lower legs from injury is important because small wounds can tend to develop and turn into difficult to heal ulcers. Nursing care is aimed at relieving the symptoms from complications of the disease and minimizing organ damage. Patients are taught to avoid high altitudes, vigorous exercise, and iced liquids. Patients are to maintain adequate fluid intake, refrain from smoking, and obtain treatment for any infection promptly. Adequate rest is important because patients with sickle cell anemia will experience fatigue. Assessment for adequate pain relief is a top priority. Polycythemia vera is a neoplastic disorder resulting in the overproduction of red blood cells. The major cause of polycythemia vera is a mutation in the JAK2 gene. This is a protein switch that tells the cells to grow. This condition is not hereditary. The blood will become thick due to the increased numbers of cells. Blood vessels become distended, and blood flow is sluggish. There is a tendency to develop blood clots. Signs and symptoms of polycythemia vera include a reddish face with deep red purplish lips, fatigue, weakness, dizziness, headache, and large spleen, known as splenomegaly, and a congested liver. Diagnosis will include a genetic test for the JAK2 V617F mutation. Treatment will be aimed at reducing the number of blood cells and preventing complications. Phlebotomy, anti-neoplastic agents, and radiation therapy can all be used. In phlebotomy, a blood vessel will be pierced and blood drawn off. As much as 500 milliliters of blood at a time can be withdrawn every 2 to 3 months. Increased fluid intake is essential to decrease blood viscosity, and aspirin can be used to decrease platelet clumping and clot formation. Secondary polycythemia does not have the same effects as primary polycythemia. The word leukemia, translated literally, means white blood. There are various types of leukemia, some more likely in children and some found primarily in adults. Specific leukemia, type, age, and physical condition will determine the best treatment options. On page 360 within Table 16.6, you can read and compare the different types of leukemia. The exact cause of leukemia is not known. Exposure to ionizing radiation in relatively large doses is one such factor. Another is exposure to certain chemicals, like benzene, that are toxic to the bone marrow. It is prudent to be careful about the breathing gasoline fumes and any household chemicals and pesticides. The third factor is the retrovirus known as human T lymphotrophic virus. This can cause human T leukemia. Malignant production of white blood cells is the actual cause of the disease. An acute leukemia is one in which there is a large number of immature cells, called blasts. These cells do not mature and stay in the bone marrow, impairing the production of healthy cells. In chronic leukemia, the abnormal cells build up at a slower rate, allowing for the production of some normal cells. Leukemias are also classified due by their origin of abnormal cells. There are 4 main types of leukemia: acute myelogenous leukemia, chronic myelogenous leukemia, acute lymphocytic leukemia, and chronic lymphocytic leukemia. In acute leukemia, there is a sudden, rapid growth of immature blast or stem cells, a rapid progression of the disease, and a short survival if the disease is not treated. Chronic forms of leukemia can have a more gradual onset, a slower disease progression, and a relatively longer survival time. Leukemia will have 3 major effects: an increased number of abnormal, immature leukocytes, accumulations of these cells within the bone marrow, and eventual infiltration of the malignant cells throughout lymph nodes, spleen, and other organs of the body. Patients with chronic leukemias are often asymptomatic, and the disease will usually be detected during a regular physical examination or routine CBC. Other signs and symptoms of leukemia include fever, headaches, bone pain, pallor, weakness, fatigue, malaise, frequent or persistent infections, swollen lymph nodes, enlarged spleen, bone pain, weight loss, and easy bleeding or thrombosis. Diagnosis will be made by using a history, physical examination, CBC with differential, and bone marrow studies to rule out any other disorders. Treatment is aimed at slowing down the growth of the malignant blood cells, maintaining a normal level of red blood cells, hemoglobin, and platelets, managing the symptoms and meeting the special needs of each patient, and exploring possible curative therapies like HCT. Acute leukemia treatment consists primarily of chemotherapy with a combination of anti-neoplastic agents targeted at different phases of the cell cycle. The drug therapy is divided into 3 phases: the induction, consolidation, and maintenance phase. Remission induction therapy will be initiated at the time of diagnosis and consists of an intensive combination chemotherapy aimed at achieving a complete remission of symptoms. Radiation therapy is sometimes used as a supplement to increase the success of treatment and to decrease discomfort due to enlarged organs like the spleen and liver. Chronic lymphocytic leukemia, the most common leukemia seen in older adults, is not treated until the patient begins to experience symptoms. At that time, a combination of chemotherapy agents is used. Leukapheresis, which is the separation of white blood cells, could also be done to reduce the massive number of circulating leukocytes that will clog organs and cause damage. Chronic myelogenous leukemia is treated with chemotherapy. Transfusions of blood components are prescribed for leukemia patients to maintain a near normal blood picture. Antibiotics can be given prophylactically during chemotherapy and are started immediately upon signs of infection due to the body's defense mechanisms being severely compromised. Collaboration with the dietitian and pharmacist is a key point in nursing care for a patient with leukemia. Infections from bacteria, viruses, and fungi are the most common cause of death in patients with leukemia. Nursing measures to prevent infection are essential. Abnormal bleeding as a result of a very low platelet count is the second most common and dangerous complication of leukemia. Observation of the patient, awareness of the patient's current platelet count, and prevention of trauma to body tissues and blood vessels as a result of low platelets are the primary concerns in nursing management. On page 362 within box 16.1, you can read about treatment for the specific types of leukemia. Anemia and its associated problems of fatigue, hypoxia, GI upsets, and cardiovascular complications will affect patients with leukemia. Colony-stimulating factor drugs sometimes can be used to counteract the anemia and neutropenia caused by treatment for leukemia. Extreme weight loss and cachexia are typically always seen in patients with advanced cancer. Metabolic changes that occur with the proliferation of malignant cells in the body are also responsible for weight loss and emaciation. If nursing measures to alleviate or minimize stomatitis, which is an inflammation of the mouth, nausea, and vomiting have not been effective, parenteral nutrition may be indicated. Tumor lysis syndrome results from a rapid cell destruction during chemotherapy. Killing the leukemia cells will release their intracellular contents into the circulation, causing a rapid change in blood chemistry. This syndrome could consist of hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia, and acute kidney injury. Thrombocytopenia occurs when the platelet count drops to less than 150,000 per millimeters cubed. This can be a life-threatening condition. Causes include bone marrow depression from chemotherapy or radiation, autoimmune diseases, bacterial or viral infections, disseminated intravascular coagulation or DIC, and overfunctioning of the spleen. Certain drugs like NSAIDs and thiazides could also result in platelet deficiency. While platelet counts are low, the primary problem is clotting. Immune thrombocytic purpura, or ITP, is the most commonly acquired thrombocytopenia. This is an autoimmune disease in which there is an abnormal destruction of circulating platelets. This disorder commonly occurs in women between the ages of 20 and 40. Many patients with thrombocytopenia are asymptomatic. Signs and symptoms of thrombocytopenia could include purpura. These are purple spots and patches in small areas, as well as multiple petechiae in the skin and mucous membranes. Also, large bruised areas caused by hemorrhage that are called ecchymoses. Hemorrhage is the major danger. Some patients recover spontaneously. Otherwise, corticosteroids can be administered to reduce the rate of platelet destruction and IV immunoglobulin, or sometimes for select patients, IV RHO immunoglobulin. Platelet transfusions are used only for significant clinical bleeding. Nursing care is focused on prevention of bleeding by careful handling of the patient, close observation for signs of spontaneous bleeding, and quick intervention. Invasive procedures are used only when essential. Patients are taught to avoid activities that could induce bleeding. Multiple myeloma is a disease in which neoplastic plasma cells infiltrate the bone marrow and destroy bone. Men are affected more often than women, and the disease occurs in African Americans twice as often as in whites. The disease usually occurs after age 40 years, with the average age diagnosis being 65 years. The cause of multiple myeloma is unknown. Risk factors include a family tendency towards the disease, ionizing radiation, and exposure to herbicides, insecticides, and chemicals, particularly benzene. In multiple myeloma, abnormal plasma cells will multiply out of control in the bone marrow. The accumulation of abnormal cells in the bone marrow can disrupt normal red blood cell, leukocyte, and platelet production. These tumors will disrupt the normal bone marrow function and weaken the bone, predisposing the patient to frequent fractures. The onset of multiple myeloma is gradual, and symptoms appear when the skeletal system is heavily involved. The patient may experience a backache, bone pain that is worse with movement, or pathologic fractures and severe pain. Multiple myeloma is diagnosed by a combination of X-ray studies, bone marrow biopsy, and blood and urine tests. A hypercalcemia that may lead to kidney stone formation and renal impairment can occur. Chemotherapy and HCT can be used to combat the disease. Pain control is a primary concern. Hypercalcemia and osteoporosis will often develop, and patients must be monitored and treated for these complications. Measures must be taken to prevent pathologic fractures. Chemotherapy regimens will be individualized to the patient based on the results of their testing. Adjunctive therapy would include radiation to target areas of pain, erythropoietin, plasmapheresis, and surgical intervention. Biphosphonates like etidronate, pamidronate, and zoledronic acid can all inhibit bone breakdown and thereby decrease skeletal pain and hypercalcemia. Encouraging adequate hydration with an intake of 3 to 5 liters of fluid per day to minimize problems from hypercalcemia is a priority. Pain assessment and management are also crucial to the quality of life for the patient. Care is taken when moving the patient due to the potential for fractures. Psychosocial care is essential because the disease has remissions and exacerbations and is eventually fatal. The patient and family must be taught about the signs and symptoms of hypercalcemia and be instructed to report these signs and symptoms immediately to the healthcare provider. Measures to prevent falls must be instituted. Hemophilia is an inherited X-linked disorder in which there is a deficiency of specific clotting factors. Classic hemophilia, or hemophilia A, with a factor VIII deficiency, affects about 23,000 males in the United States. Hemophilia B, or Christmas disease, causes a deficiency in factor XI. Both types of hemophilia are characterized by a delayed blood coagulation that produces a prolonged period of bleeding after injury or surgery. These types of hemophilia almost always occur in males and are genetically transmitted through the mother. Female carriers of the X-linked recessive condition are usually asymptomatic, but under certain conditions could exhibit mild hemophilia. Acquired hemophilia can affect both men and women, but the disease is rare. Von Willebrand disease, also termed VWD, is a genetic disorder in which the VWD clotting factor is absent or defective. In its absence or dysfunction, platelets will not clump correctly. This affects men and women equally. In all types of hemophilia and VWD, there is a decrease in the amount of activity of one or of the 11 different clotting factors normally present in the blood. They are essential to the formation of clots. There are varying degrees and severity in the types of hemophilia, depending on the amount of factor present and that role of the factor in clot formation. The most obvious symptom of hemophilia and VWD is bleeding. The hallmark of hemophilia is bleeding into joints, causing loss of mobility and unequal extremity lengths. Hemarthrosis, which is bleeding into the joints, will produce swelling, pain, warmth, and limitation of movement similar to that experienced by patients with rheumatoid arthritis. If the bleeding occurs in the intracranial spaces and therefore increases intracranial pressure, the patient could experience convulsions and brain damage that could be fatal. Bleeding in VWD presents as a history of bleeding problems, like frequent nosebleeds, easy bruising, and longer than normal bleeding after injuries or a minor surgical procedure. Diagnosis is by history, physical examination, CBC, coagulation profile, and tests for the various clotting factors in the blood. Recombinant forms of factor VIII and factor XI are available and can be administered IV at various dosages and intervals based on clinical data. For mild hemophilia A and for subtypes of VWD, desmopressin acetate, a synthetic form of vasopressin, can be given to stimulate an increase in factor VIII and von Willebrand factor. Analgesic drugs and corticosteroids can be used to treat joint inflammation and pain caused by the hemarthrosis and by the common resultant arthritis. In addition to administering the necessary clotting factors, interventions will include elevating the injured body part, applying cold packs, controlling pain, observing for further bleeding, and providing psychological support to the patient and family. You should also encourage genetic counseling for family members. Disseminated intravascular coagulation, or DIC, is a complicated disorder that usually occurs in conjunction with tissue destruction. It is not a disease. Instead, it is a complication of a significant clinical condition. It can accompany serious problems like severe trauma, gram-negative sepsis, shock, respiratory distress syndrome, malignancy, transfusion reaction, amniotic embolus, and abrupto placentae, which is a separation of the placenta from the uterine wall. DIC can present as a life-threatening emergency or could be a chronic subclinical process. The first signs of DIC are usually continued bleeding from an injection or IV site, extensive bruising in areas of injury, ecchymosis where there has been no trauma, and petechiae. There may be oral, vaginal, or rectal bleeding. Laboratory studies will reveal a decreased hemoglobin and a low platelet count. The INR and activated partial thromboplastin times will be increased. The fibrinogen level reduced, and the fibrin degradation product level will be increased. The D-dimer result will be elevated. Treatment consists of correcting the underlying problem. Packed red blood cells can be given to support circulation and perfusion. Fresh frozen plasma may be given to replace clotting factors if significant bleeding is present, and platelets can be transfused if the platelet level is below 10,000. As a nursing priority, be alert to the possibility of the development of DIC whenever a patient has a condition that predisposes them to it. Chronic DIC is more likely to be present with thromboembolic complications because clotting factors are not used up quickly and the replacement products are manufactured by the body, keeping pace with those consumed by clots. Some types of leukemia could also cause a chronic DIC. If clinical symptoms are present, they will be represented by the organs or organ systems affected by the clotting. A blood transfusion involves the administration of a blood component. Blood usually is transfused only when there has been a large blood loss, when the patient has a deficiency of a blood component, or when there must be a total blood exchange in a newborn. Autologous blood transfusion is commonly used when the patient's own blood can be collected and reinfused. The blood will be collected either during or after surgery, like from a chest drainage, or blood that is donated from the patient during weeks before surgery for later use. Several artificial substitutes for human blood are being tested, but none of them can provide all of the functions of human blood. Special precautions will be taken whenever any blood component is given. Blood banks have written procedures and policies for withdrawing and dispensing blood for transfusion. Blood products are always checked by 2 nurses before administration. Some facilities will require that 2 RNs check the blood, and some will allow an LPN with appropriate training to be one of the 2 licensed nurses. Always check your facility's policies and procedures. On page 369, within Table 16.7, you can read about the different blood products and their uses. Determine whether the patient has an IV site already established and note what size catheter is in place. If rapid infusion is needed, you must give blood through at least an 18-gauge catheter. Slower infusions can be given through a 20 to 24 gauge device. The only solution that should be used with the blood is 0.9% saline. No other fluids or medications should be given with the blood or any other blood component unless they have been FDA approved. The administration set should be primed and set up prior to obtaining the blood. After obtaining the blood from the blood bank, it must be infused within 4 hours. If the blood is not going to be infused, it can be returned to the blood bank if it has only been out of the refrigerator for 30 minutes or less. Blood infusion sets can be used for 4 hours or for 2 units of blood. If a second unit of blood can be transfused within the 4-hour window, the same administration set can be used. All blood must be filtered. Blood products are typically between 200 and 300 mLs. It's important to assess for your patient how well they could tolerate the colloid fluid volume in that time frame required. If a unit of blood is to be given slower than over 4 hours, request that the blood bank divide that unit. The word reaction means sensitivity to the blood itself, or sensitivity to the preservatives or other substances that have been added to a solution. Reactions to red blood cells are the result of incompatibility between blood types. A major blood reaction usually results from giving the wrong blood to the wrong patient. A mild reaction is usually caused by antibodies in the donor blood and not the actual red blood cells themselves. On page 370, see the red safety alert box. The symptoms of a transfusion reaction could be so mild that they go unnoticed, or could be so severe that death is the outcome. In milder cases, the patient may develop a rash, hives, itching, or facial flushing. In more severe reactions, the patient may experience a variety of problems, including shock. Diphenhydramine hydrochloride can be ordered IV if itching or hives occur. In severe anaphylactic reactions, the treatment will be the same for anaphylaxis caused by any extreme hypersensitivity. Other signs of reaction include the patient's temperature rising 2 degrees above the starting temperature. If any significant reaction occurs, the infusion must be stopped, the IV kept patent, and the healthcare provider notified. As long as there are no signs of adverse reaction, the patient should be assessed and vital signs taken every 30 to 60 minutes until the transfusion has been completed, depending on your agency policy. On page 370 within table 16.8, you can read about some acute transfusion reactions. Leukapheresis is a procedure performed to clear excessive white blood cells from the blood. When performed directly, the patient will be connected to a blood separator machine. This treatment can be used to lower the white blood cell count in patients with CML and is sometimes used to treat certain immune disorders like myasthenia gravis. Erythropoietin can be given parenterally to patients with decreased erythropoietin resulting from end-stage renal disease or who have suppressed bone marrow due to the toxicity of chemotherapy given for malignancy, rheumatoid arthritis, or HIV. Granulocyte colony stimulating factor can be given parenterally to combat neutropenia. HCT is aimed at providing healthy blood cell producing capability when the patient's own bone marrow is faulty or has been destroyed by chemotherapy, or irradiation during attempts to rid the body of leukemic or other cancer cells. The cells used for transplantation can be allogenic. This means from another person, or autologous, from the patient. Peripheral stem cells from umbilical cord blood, or from bone marrow will be used for transplantation. Bone marrow harvest is typically done in the operating room, where multiple aspirations from the iliac crest are performed. Nursing care after the harvest will consist of monitoring the dressings for bleeding and medicating the donor for pain in the hip area. The patient will undergo a conditioning regimen to rid their body of malignancy or obliterate the diseased bone marrow. This process typically takes 5 to 10 days. It involves intensive high-dose chemotherapy and often includes total body irradiation. At this time, the patient is at an extreme risk for infection. At least 2 days after the end of chemotherapy, the stem cell infusion will take place, typically through a central line over approximately 30 minutes. Engraftment can take 2 to 5 weeks, and it will be considered successful when the patient's erythrocyte, leukocyte, and platelet counts begin to rise. Until engraftment is complete, the patient is at a dire risk of infection and hemorrhage. Other complications include failure of engraftment and graft versus host disease, in which the cells see the patient's tissues as foreign and will mount an immune attack. Low concentrations of oxygen can be administered to relieve severe dyspnea and hypoxia during the acute phase of a blood disorder. Target SpO2 should be no more than 98 to 99%. When the body lacks iron, the amount of hemoglobin is decreased in the red blood cells, making them very small and pale in color. In simple iron deficiency anemia, the condition is relieved by administering iron salts. Although iron salts are absorbed better from an empty stomach, they are still irritating to the GI tract. The patient should be warned that taking iron salts by mouth will produce a greenish-black stool, and there is no cause for alarm if this change in stool occurs. Some patients will suffer such severe gastric disturbances from the oral intake of iron salts that the medication must be given by another route. Ferric carboxymaltose injection and ferumoxytol injection are approved for IV administration. Vitamin C is usually given with iron because it will enhance iron's absorption. Vitamin B12 is needed for red blood cells to develop into mature, normally functioning cells. Second, vitamin B12 is necessary for nerve cells to function normally. Another B group vitamin, folic acid, will also be needed for red blood cell maturation, but it has no effect on the nervous system. Vitamin B12 can be used to treat megoblastic anemia. Injections of vitamin B12 will be given daily for the first few weeks, and later can be spaced a week apart. As the patient improves, vitamin B12 injections could be necessary only once a month, but these injections must continue for the duration of life for patients with megoblastic anemia. Patients with nutritional anemia should eat nutritionally balanced, high-protein meals. Indications for the surgical removal of the spleen would include severe trauma to and rupture of the spleen, splenomegaly causing destruction of blood cells, and blood disorders caused by the spleen. If the spleen is removed, the other organs of the monocyte macrophage system will take over many of its functions. Individuals who no longer have a functioning spleen are at a very high risk for developing life-threatening infections, especially those caused by pneumococci. A patient with a ruptured or torn spleen is in immediate danger of hemorrhage and shock. Non-surgical approaches will be implemented to save the spleen due to its important role in the immune system. Patients with blood disorders can be treated in many different places in the community. Patients with blood disorders are commonly treated as home care patients. In some instances, blood products can be administered at home. Some types of chemotherapy agents can be given in the home setting, and the patient must be monitored for all of the same adverse effects that these therapies can cause. Home care nurses must do considerable patient and family teaching about the prevention of infection, prevention of and treatment for bleeding episodes, appropriate nutrition, and the regulation of medication.